Shasha. In this talk, I'll be going over a visual representation of 40 different ophthalmic conditions. We'll be starting from the top and working our way all the way towards the bottom. In our first image, we note ptosis, mydriasis, and that the eye is down and out. This is classically seen in compressive etiologies causing a cranial nerve 3 palsy. In the second image, we again note ptosis and the fact that the eye is down and out, but however, the pupils are equal in both eyes. And so we call this a cranial nerve 3 palsy, more likely to be a vascular etiology like diabetes. In the third image, we note ciliary flush and a mid-dilated pupil relative to the unaffected left eye. This is seen in acute angle closure glaucoma. Now, it's important to note that ciliary flush can also be seen in iritis. However, the pupil is not usually mid-dilated, but rather miotic. In the fourth image, we note the classic dendritic appearance in HSV. If we were to magnify this, we would see terminal bulbs. However, if there were terminal endings, then that would be more classic of herpes zoster ophthalmicus. It's important to note that, of course, to see these dendrites, we use fluorescein staining. In the fifth image, we note hypopyon, which is a layer of inflammatory markers in the right eye. This is seen in endophthalmitis, Behçet's disease, and other inflammatory conditions. We are going to ignore the second last image as this was created in error. In the last image, we notice a pannus formation, which is blood vessels encroaching around the periphery of the cornea. And this, of course, has multiple etiologies. One can be attributed to contact lens. Again, starting at the top here, we notice that there is a fibrovascular structure encroaching and is now on the cornea. This, of course, is a pterygium. This may need surgical intervention if it continues to grow and ultimately affect the patient's vision. In the second image, we notice ectropion secondary to lid laxity. This, of course, can cause inappropriate lid closure and corneal dryness. In the third image, we notice a layering of blood in the right eye. This is called a hyphema, and again has a multitude of differentials. One, of course, can be an iris tumor, neovascularization of the iris or the angle, and more commonly, trauma. In the fourth image, we notice vortex shape called Vortex Keratopathy. This, again, has several causes, but the main thing to consider is amiodarone use. Patients are often asymptomatic in this condition. In the fifth image, we note a focal area of hemorrhage under the conjunctiva. This, of course, is a subconjunctival hemorrhage. It can be seen in trauma, in Valsalva maneuvers. It is visually insignificant in that it does not affect your vision and will resolve with time. In the second last image, we see the opposite of ectropion and entropion. Unfortunately, with the lids pointing inwards, the lashes can cause corneal damage. In the last image, essentially an inverse of a hypopyon, is a layering of silicone at the upper portion of the cornea. This can arise after certain retinal surgeries. In the top image, we note xanthelasma. This can be seen in patients with high lipid values in their blood. In the second image, we note anterior chamber IOL in the right eye. Now, this is not a disease in itself, as in some cases it's necessary to place an IOL in this region, but it's important to highlight. In the third image, again, we note something that can be therapeutic and is not technically a medical condition. We call this a peripheral iridotomy, which is seen in the right eye. And this can be very helpful in cases of acute angle closure glaucoma. In the fourth image, we note in the right eye conjunctival injection and green purulence, commonly seen in bacterial conjunctivitis. In the fifth image, we notice Arcus Senilis, which is asymptomatic and seen with age, usually affecting both eyes. The next image, like Arcus Senilis, is circular in shape but requires a workup. Here we're describing kayser-fleischer-ring, which we see in Wilson's disease. The last image, it's appreciated when we have the patient look down and we notice a bulge inferiorly in patients with keratoconus because of the way their cornea is shaped. This is called Munson's sign, and it's usually not an early but rather a late sign of keratoconus. In the image above, we notice increased iris pigmentation, lengthening of the eyelashes. This is because of prostaglandin in patients who are taking it for glaucoma. In the second image, please pay attention to the fact that there is meiosis as well as ptosis. This is seen in Horner syndrome. It's important to highlight that the ptosis in Horner syndrome is mild relative to the ptosis in cranial nerve 3 palsies. In the third image, we notice a ciliary flush, which I described earlier, but the pupil in this case is miotic, classically seen in anterior uveitis. In the fourth image, we are asking the patient to look to the far left, and here we note an upshoot in the right eye associated with a cranial nerve 4 palsy. In the fifth image, we notice horizontal deposits across the cornea, classically seen as band keratopathy, related to excess calcium levels. The last two images are seen in inflammatory conditions. These nodules are important to look out for when seeing patients with uveitis. The image on the top in this slide depicts mydriasis. This can be pharmacologically induced, or it can be physiologic. It can also be seen in other diseases like Adie's tonic pupil. In the second condition, we notice difference in iris color. We describe this as heterochromia. In the third image, we notice prominent blood vessels in the iris structure. This is referred to as rubeosis and can be seen in diabetic retinopathy. In the fourth image, we notice iridodialysis, where often secondary trauma, the iris detaches from its anatomical landmark. This can have impacts in terms of intraocular pressure and can, in some instances, produce profound photophobia, which may require surgical intervention. In the second last image, we notice a slit in the right eye with keratic precipitates on the endothelium. This, of course, is classically seen in anterior uveitis. Finally, in the last image on this slide, we note that the a bluish rather than the white clear structure, and this is because of different collagen makeup seen in osteogenesis imperfecta. In the top of the image here, we note the iris coloboma. It's important to realize there's other associations with this. This is a genetic condition. In the second image, we note that the left eye is higher. We refer to this as hypertropia. In the third image, again, we notice a coloboma. In this case, however, it is of the lid of the right eye. In the fourth image, we note, instead of a bluish color seen in osteogenesis imperfecta, we see a yellowish color of scleral icterus. And this should highlight to the clinician of liver disease. In the second last image, we have everted the patient's lids, and we are seeing conjunctival pallor in association with patients with anemia. Finally, we see in this condition widely displaced eyes. This is referred to as hyperterrorism and is seen in many genetic conditions. That concludes visual representation of 40 ophthalmic conditions. I hope you found this useful. If you have any questions or comments, please write in the comment section below, and I'll respond to you as soon as I see them. Thank you.